Greetings to all. I am Dr. Carrasquillo, and I would like to begin by thanking Contamac for the invitation to be part of the CLASS symposium again in this year 2021. And today I would like to discuss a topic with all of you. We talked about how we can push the limit with scleral lenses and what we can do both in the posterior curve, now obviously, and in the anterior curve, to be able to transform cases that suddenly we think are not viable for these lenses, and to turn them into successful cases. To begin with, I would like to disclose my financial disclosures. I am the Vice President of Clinical and Professional Affairs at Boston site, but I have no proprietary interest in any of the Boston site lenses or technologies. To begin with, to frame today's talk, we are going to deal with three main themes. One is how we can visualize, idealize, and push the boundary when dealing with significant bumps beyond what is pinguecular and beyond what is pterygium. Cases that, if we do not adapt in a slightly more creative way, we can compromise the physiological functioning of these patients that are with us. And we are going to see the case of fragile or transplanted and compromised corneas. And finally, cases where suddenly everything seems to be adequate, where everything seems to have an optimal result. However, patients tell us that their day-to-day functioning is compromised. And so we are going to start the talk and see how it is possible that we can push the limit or what we can do with these lenses. In the first topic, as I told you, we are going to focus on three cases that we are going to discuss about significant protrusions that, as I said before, if they are not a little creative, we can suddenly compromise the function or the physiological result of that ocular surface. The first case that I'm going to show you is a case of keratoglobo, and we can appreciate in this topography that we show you here the thinning that goes from the edge to edge of the characteristic of keratoconus. And so this is a patient who has a history of scleral lenses but without success. And this is a patient who had a lamellar graft in the nasal area, and when he presented it in our clinic, he had developed a cyst in that corneoscleral area, and where apparently the anterior scleral lenses that the patient used were generating too much, a lot of compression in that area, which can be fragile because it is extremely thin to begin with, and the patient does not tolerate wearing lenses. And so how can we push the limit of what we want to do without compromising or affecting the central vaulting of that scleral lens, or the vaulting in other parts of the cornea, right? Where I only want to vault a local area, that I protect that cyst so as not to compromise that cornea, so that is already fragile because of how delicate it is, right? And if I can devise or visualize that I can suddenly design a canal that vaults this area only in a local way without compromising the other parts, I could push the limit a little bit, but take this case of scleral lens failure to a higher level. And really what we are going to see is to estimate that thickness so that these channels or these vaults, when they rest on our surface, rest in a smooth way and thus do not develop symptoms or signs of compression. We see that you can see the extent of that thickness using the permanent ink marker on the lens. And on the first lens, you order that for the patient. And that lens is not going to be used because it does not have the proper vaulting, and so we can mark to get a better idea of where we are going to start that vaulting and where we are going to finish it. and then we estimate that depth. And we see that if we devise it and visualize it, and we can count on the technology to be able to do this, this is something that we can do in our clinic, and we can design it ourselves, but it is something that is suddenly you can talk with your different manufacturers, with your different designers, to help them achieve this type of personalization. And let's see here that what we are really creating is a channel with new sclerals that extends from the area of the sclera to the optical area of the lens. And when we stain with sodium fluorescein, we see that have a complete vaulting. And we can observe in the same presentation when we are looking at the slit lamp in the optical zone. And ultimately, when we remove the lens, which is the final proof that we have here, is that we do not see any sign of hyperemia when we remove the lens. And, well, in particular, as we show you here, we have no signs of tension, and that it is a sign that we are not having any touch, no friction on that cyst, and that we are protecting that tissue that is fragile and compromised. So in the second case, I am going to take you a little more by the hand so that we can discuss how we are going to do this and how we can order these types of channels when we are working with our manufacturer. This is a case of post-transplant keratoconus, who used the lens for many years in my clinic. He is a patient of mine, just to be able to see. But this patient also has a history of glaucoma and eventually required an Ahmed valve in order to adequately control intraocular pressure. Despite the fact that we consulted with the glaucoma specialist and we suggested trying to put that valve as later as possible, even when that discussion was had, let's see that in the second image that you can see this valve here, but we look here in this position of this limbus that despite him trying to put that later, that conjunctiva is quite elevated and that goes just to the edge of the limbus. And if I were to land in this zone tangentially, which is how we would usually land otherwise, we would be exerting significant compression. And all of a sudden, it's the least I'm going to worry about, because if I induce severe compression, I could potentially be compromising the operation of that valve and that tube, which in the end compromises intraocular pressure. And so in this case, it is beyond apinguecular, beyond that there is a pterygium here that involves an optimal physiological result. So what am I going to do? I am going to take the same reasoning, the same process, and I'm going to approach it in the same way, and I am going to try to spot a channel or a local vaulting that only protects this area where that valve is, and I am going to do it sufficiently wide to, again, rest in a smooth way. And I'm going to estimate the width, right? And to estimate that width, I can use the slit lamp because you have a nut where we can see that measurement in degrees, and where if I place the optical section in this position, I can see that it is around the position of 520 degrees. And so if I estimate it roughly in this region, it is roughly at the 165-degree position. So about 20 to 45 degrees, and then I go on to estimate what is the elevation we have in this case. And the presence of the scleral surveyors can take these types of elevations and measure exactly where the elevation is and tell us exactly how deep we should design that channel.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
But if we do not have the presence of scleral surveyors, I suggest that as a starting point, when dealing with presentations like this that we at least design a channel of at least 400 microns in elevation. When we do this, we can imagine, right, how that scleral lens then rests in the part of the sclera that is adjacent. But we can see in that thickness how, more or less, this channel would look like with the estimate of 400 microns, where we would be protecting, covering that area without having no touch from the back curve of that lens. And the final result is this one that I show you here. Now let's see here. Here we can appreciate Ahmed's valve and see here the extension where the tube is. And in this image here in the center, we can see the extension of that channel here that I outlined for you to make it easier to visualize. But in this photo here at the bottom, to be able to appreciate the significant elevation that this tissue has conjunctival, right? And we have to significantly flatten and ultimately design these specific lenses. And let's see here the extension of that channel. And when we do it in this way, when we remove this lens, we not only see that the eye looks calm, as it is not, there are no signs of hyperemia and signs of compression or swelling. But when we remove the lens, we do not have tension, and we are protecting that area so as not to compromise the function of the valve. Number one, but we are not avoiding severe friction on the conjunctiva that can lead to conjunctival erosion and perhaps endophthalmic complications. So please keep in mind that you can approach your cases in the same way. And the last case in this series is another patient who presents with corneal ectasia to be able to see. Fitted for so many years in scleral lenses, and suddenly his latest history of an intraocular lens in his subluxated left eye, which requires repair and also undergoes a vitrectomy and mild retinal detachment repair. Once the patient gives the go-ahead to resume the use of the scleral lenses, the patient presents in this way. Here we can see in this image something that, right off the bat, looks disturbing, and we can see the extent here, in indirect light, what appears to be an exposed suture. I am not entirely sure when I am starting to analyze this patient, but when I remove and see here, once we stain, we see the extent of that hyperemia, of the excessive compression that there was, and ultimately we see the presence of an exposed suture. Already in these cases, when we have cases like this is a case that the patient must be educated on, because this presentation presents a severe risk of infection complications, because we have an exposed tissue and potentially endophthalmitis. So you have to continue in classes, and you have to send the patient with a certain degree of emergency, so that the patient can fix this presentation. And the way the surgeon is going to arrange this presentation is that he is going to place a scleral graft. And these grafts are known as tutoplast. And in this case, they use a 2x5 mm, and where the conjunctiva is pulled to cover that graft, and then they suture it with these vicryl sutures to keep it in place. You can already imagine that with this type of manipulation and that conjunctiva, that anatomy is going to change significantly, where that geography is going to be the same, and we are going to have different elevations. When the patient is given the OK to return, we see that when he presents in the clinic, we have this type of presentation, and we see a significant compression in this nasal region of that left eye, and also in the upper temporal region, where especially this area where we have such severe compression, it is in the area where we had that cognitive, but that exposed suture, and where we really want to avoid a severe touch. So, we do the same. We see the extension of a local vaulting in both regions, and where we go on to the design of the lens and obtain a result as you see. Notice that this would be the canal on the nasal side, and this would be the canal in the upper temporal degree, and where we estimate how we achieve the thickness in the same way by marking on the lens. This is a 160-degree position and a 200-degree position, so we designed a channel in total of 40 degrees thick, and in this case, as the extent of the bulge was not significant, the channel was just 20 degrees thick, and where the depth in this case was 250 microns, and on this other side, simply 150, because it was a little less high. And by doing this, and pushing the limit of what I can do with these scleral lenses, I have to ultimately, when I remove, or before removing the lens, I am going to tell you, we see a presentation that is more physiologically compatible with this presentation on the surface ocular. Where the eye is already calm, it is white, and we do not have signs of severe compression or swelling. And when we remove the lens, we see that we do not have a signal or a response of hyperemia, and we have much less tension in those nasal areas and superior temporal areas. And so this is an indication of a result that is physiologically compatible. Just pushing the limit a little bit, modifying that bat curve. And let's take into account, because this can be super viable for many cases for our patients. Now, the second topic that I want to present to you is discussing when we have very fragile corneas, very compromised, or transplants that are already very old, that many people will think that scleral lenses are no longer viable. So how can we push that little limit, and so that these patients keep wearing these glasses? The first case that I want to share with you is one of Stephen Johnson's patients who is monocular, and I have been treating this patient since 2006. She is monocular in the right eye, and in the left eye it is her only good eye. The right is completely conjunctivated, and therefore the only thing she has is the perception of the light in that eye. And from the outset, in a case as compromised as this one, I adapted this patient to a 19.5mm lens, because not only am I protecting this cornea from dryness, but I am also protecting the cornea or the ocular surface from microtrauma that these eyes suffer from their same microenvironment, such as the keratinization that occurs in the eyelid and the improper and insult that can occur due to the eyelashes in these patients. I customized this lens in a specific quadrant way. I already started to push the limit of what we could do then, but in 8 quadrants. And the patient, for 12 years, was able to use the lens successfully in a vision of 20/30 and 20/40. But on some occasions, tear particles did accumulate in the optic zone of this lens, and from time to time, the patient needed to remove the lens and relocate it. This is how the cornea of the patient looked when I was handling it for 12 years. And this is a diagram of how we can personalize our scleral lenses in our clinic, where we personalize more than up to 4 quadrants in up to 8 quadrants. And this was the type of adaptation that this patient had, but the patient decides, without them knowing it, and he looks for other alternatives outside of our clinic to be adapted in another way, to see if he can avoid the tear particles that enter the optic zone. They then adapt it to a system, a mold printing technology, and all of the diameters that the adapter could choose, he chose one of 16mm and adapts it with a super low volt, perhaps concerned about the effect of hypoxia, perhaps fearing that this could more potentially compromise this cornea. But when we do these things, especially when we work with cases of ocular surface disease, we have to have a whole frame of everything that we are dealing with, not just a plastic lens fitting and think that all fittings are the same, and why not they are.
Whether you're helping your patients with the daily irritation of dry eyes or combating other ocular surface diseases, Boston Sight Scleral has the data-backed science and experience to help them see the world through a whole new lens.
In this case, we have to see that it has been studied that smaller diameter lenses settle more with time compared to a larger diameter lens. And this adapter, having been adapted with such a low dome, so low this lens is that it settles over time, which gives way to a corneal touch. And we are dealing with a case of stem cell insufficiency in the limbar area. So it does not have the ability to regenerate that epithelial layer. This touch will give way to persistent epithelial damage and quickly gives way to corneal melting because it does not have the ability to heal. And I must say that I did not have adequate control or monitoring. Once this happens, a monocular case of corneal melting, they have to treat it with PED. So the patient now returns where visual acuity is decreased, where we have an even more severe opacification. And we can see, and where we have the presence of microcystic edema at the baseline. And we can expect the edema to get worse with the use of the lens. And they try to see how I can push the limit with the scleral lens so that this patient who is monocular, who is 40-something years old, can have a functioning quality of life. At that moment, the only thing that I think is viable is to look for strategies to minimize suction. So the first thing I'm going to do is readapt this cornea back to the 19.5 lens to continue protecting that ocular surface, because not only the cornea or the edema, but I want to protect the ocular surface in general. And I'm going to find ways to customize that posterior area by adding channels in those haptics, but this time to minimize suction. And I will tell you in a moment how we do that and where I am going to add the fenestrations in that haptic area to prevent suction in addition to the channel. We do not add fenestrations in the optic zone because that will give me a bubble. And in the case of such dry corneas, these bubbles can exacerbate the symptoms of dry eyes. And so we defer the use in these cases and reverse the fenestrations for the scleral rest zone or the haptic zone. Great. So here I show you what it looks like. What that fenestration in the upper part looks like. We see the lens as it is adapted and we have a good alignment, and this is what the channel looks like when we use it to minimize suction. Note that the depth of these channels is not great because there are no protrusions here. Here we only need enough, and we are talking about 150 to 200 microns, to prevent the lens from drying out. And with this strategy, we were able to stabilize this cornea, as you see here. And you can see that we do not have any presence of edema. And we improve the vision at 20 to 80. But something told me that this cornea, suddenly, was not necessarily a 20/80 cornea. Perhaps because of something that I already knew, and that if you do not know, I want to share with you today, so that you know or challenge yourselves to think that if we have a vascularized and opacified cornea, that we do not rule out of the possibility of being able to improve the vision simply because we have opacification or vascularization. Over there, in 2016, we began to notice a succession between Stephen Johnson's and with the development of secondary corneal ectasias. We reported these findings in 2016, and then there are other groups that have reported a similar association. More recently, a group from Japan, where they report the presence of high-order variations in these cases of secondary ectasia. where the ectasia develops after diagnosis by Stephen Johnson's. Then something told me that all of a sudden my patient might have an element of ectasia. I tried to get a topography, and even though the topography was not of the best quality, I did have evidence that there was an element of ectasia, and I began to push the limit of what I could do with that scleral lens, where not only did I personalize that posterior area in 8 meridians, where I added channels in the posterior area, where I added fenestrations in that haptic, but also began to modify the anterior curve, really pushing the limit, changing different eccentricities in the anterior curve to see which one gave me the best result to get some aberration control. And when we used this approach and we were able to challenge ourselves, we were able to bring this cornea to C2030, which was the visual acuity that this patient saw before this corneal melt. And with this approach of minimizing suction, we do not have the presence of edema, as we can see in this image, and where, after 4 months, we can see that these corneas have a clearance that is being seen after these 4 months. As little as 4 months after using this scleral lens. So this case is really an example of how we can really push the limit of these deformations in order to transform a case that could be disastrous into a successful case. I already told you about this other case. This case is a case of keratoconus, where we are also going to see how, by minimizing the suction, we are pushing the limit of what we can achieve with our patients. This patient has original transplants of almost 40-something years old, where we know that this health, that capacity, and that the vision is going to deteriorate over time. And ultimately, we had to add the fenestrations in the optic zone for 2005. And when I adapted and adopted this patient, because it was from another doctor in my clinic, and I adopted him and began to adapt it with fenestrations in the optic zone to be able to eliminate the presence of edema that this patient developed at that time. We did this strategy thinking 2020 for years, but the patient recently presented with a complaint that his functioning is already being compromised because this bubble is already becoming a little bigger, and he is sometimes affected by the central axis and the central addition. And at night, he has a lot of complaint of glare with the lights. So, last year at class, I commented on how we can design these lenses, and as I discussed that one way is, if we can lower the loop as much as possible, we can see in this diagram, if we have designs where the loop is regardless of the base curve, I can, as is the case with our designs, steep the base curve independently of the sag in order to minimize the vaulting in that peripheral area. And so, that bubble remains in that periphery. Well, that's what I tried to do for years, but already the cornea was so asymmetrical that it wasn't going to give me the results. So, how can I push the limit and make this original nearly 40-year-old transplanted cornea still wear scleral lens? You have to devise and visualize what may be possible. So, we thought, is it that suddenly, if I design a channel, but in this case, it is not the haptic zone, but in the optic zone, and I design it in a circumferential way, will it be that I add fenestrations to it? Along that channel, can I limit those bubbles to staying on that periphery? Well, I tell you that is what we did, and notice here in this video how the bubbles are starting to get much smaller, where we are really limiting them to that edge on the periphery, right? And where we are going to see very soon that when we lift the eyelid, we are going to see that these bubbles are really limiting themselves to that peripheral area of that channel. And we were able to achieve what we were, which was our goal. Now, if you look here, how that bubble is in that peripheral area, and if I show you some photos, we see here in the images how we have those little bubbles limited to that area of the circumferential channel. We can again achieve 20/20 and achieve an adaptation now physiologically compatible in a transplant of 40 years to be able to continue to be this successful with a scleral lens. So we keep pushing the limit of what we can do, and we have to visualize, devise, and try to achieve it. And if we don't treat it, we will never know what is possible. Am I right? And finally, the last case in this series of fragile and compromised corneas, I present this case. This case, as we can see, is a case of keratoglob with a 20-year history of using scleral lenses, adapted in another clinic, and where the patient is again monocular. And these are very important risks and considerations that we have to take into consideration, because this patient is monocular, because in the right eye he had a corneal transplant that was not successful, and he had a complication of a total retinal detachment. Thus, this patient has light perception of vision and, in fact, wears a prosthesis in his right eye. This is his only viable eye, and corneal transplantation is the last thing the surgeon will consider given the high risk of this patient. And where the patient presents with a super tight scleral lens, where he has corneal touch in almost 2/3 of the cornea, and where there is a presence of basic microcystic edema with the use of the lens in a vision of 20/70. And we wonder what we can do. How can we push the limit of the scleral lenses so that this patient can wear the glasses again? Well, I share that I am going to use the same strategy that I used with the previous keratoconus patient that I just presented, but this is a much more protruding cornea and much more irregular. And here I decide not to play right, and here I did not use a single fenestration or 2 fenestrations. I added 3 fenestrations in the optical zone. Now notice how protruding this optic zone, this is a 20mm lens, and I added in addition a fenestration in the haptic zone. I threw it with everything. And we can see that with this strategy, we see that we managed to stabilize that vision at 20/40, where we no longer have edema because we are minimizing the suction, and where we can really keep the bubble on the periphery. And we want that bubble to be free, to move, because if it does not move, it can cause corneal damage. So we want to avoid this. And notice how in the video we can see that the bubble stays on the edge and on the periphery, where it does not affect me, and the patient can see 20/40. And we have already been 2 years after this adaptation, and the patient can wear glasses for 10 to 12 hours, pushing the limit of what we can do a little bit. Now keep in mind when dealing with fragile and compromised corneas and as in these cases. Now, finally, to finish, the last issue is when we have a compromised operation and our objective data tells us that everything is fine. This case that I present to you to end today's talk is a keratoconus patient with a history of dry eye and a history of chronic allergies. Nothing very severe or drastic really. It is something that all of us can relate to. However, this patient, for years, had been complaining to me that her daily functioning, his accounting, deals with many numbers on the computer with many hours, and it is compromised. He tells me, I can't read, it is difficult for me to read, and it was something that did not fit me because despite me doing all of this, that I number you here, I discarded residual astigmatism. I played with it, and I tried to change the eccentricities in the curve above. And I tried to add HP in the anterior area of the lens to see if I could minimize the disturbances due to the dryness, thinking that, all of a sudden, that was what was affecting my vision or functioning. But despite all this, I ended up with a 20/20 distance vision and a 20/25 near vision, and based on this objective data, this patient should, in theory, be happy. And however, she told me that for 2 or 3 years, we were struggling, saying, Karen, I can't see properly, I can't do my job. And this shocked me a lot, didn't it? Already once, thanks to the technology and technological advances, I think that may be happening. But later in our clinic, we have to access an aberrometer, where we can measure high-order aberrations in these visual systems and see what is going on. And something told me that this was where things were going, and that if the patient was really complaining, she was not complaining just to complain. Well, when I proceed to measure the aberrations of his visual system, I noticed that in the right eye and in the left eye, we see the simulation of how the patient sees. And we see that the letter E, despite that visual acuity, is objectively not sharp. We see that we have quite significant ghost effects, and where here we can evaluate what is known in English as the point speed function, which is basically a function that the more the image unfolds, the more blurred that the image is. So we see, especially in the left eye, which is quite significant, and it is the patient's non-dominant eye, which is the one that favors the near vision, as we know. So that's where I say, let's see how I can push the limit of what I can do with these scleral lenses. And if I can quantify these high-order aberrations, as I show you here, and really if I can neutralize those aberrations in a custom way and add the curve to the anterior curve of the lens, I can perhaps improve the function of that patient. We proceed to do it, and we see that we pass from this scenario, from a very blurry E to a sharper E, and where the point speed function of that image is super sharp and much sharper, where in the left eye we have a similar result, and we go from this scenario to this scenario in the visual simulation, and where again in the eye that is non-dominant, that point speed function, we are improving it significantly, and we do not have a display of that meaningful image. And where we have that visual acuity, it improves to 20/20, both at distance and up close. But more than anything, and most importantly, is that the quality, the subjective responsive of the patient is overwhelming. And where the patient tells me, Karen, for the first time in years, I can feel that I can function and do my job properly, and I can read. So the simple fact of continuing to listen to the patient, which is an art in itself, and not dismissing it as a complaint, and then wanting, devising, and visualizing what may be happening and pushing the limit of what we can do with the lenses again. And we can truly affect significant impacts by changing and improving the quality of life for our patients. So with this case, I leave you. Thank you for your attention, and in conclusion, really complex cases do require strong solutions, right? Great solutions, but we have to idealize and soften what we want to do for our patients and collaborate with our manufacturers to help us see if it is possible to achieve what we want for our patients specifically, and that we know that there is not much that can be done. Make both the back curve and the previous curve today. And hopefully, even more we can do in the future. So again, thank you very much for your attention, and thank you Contomac again for the invitation. See you soon.